Hi, I'm Jason Springer. I am one of the co-directors at Vanderbilt University Medical Center of the Vasculitis Center. So we know that adenosine deaminase 2 deficiency is a monogenetic autoinflammatory disease that can cause vasculitis of medium-sized blood vessels. And it can mimic a form of medium vessel vasculitis called polyarteritis nodosa. Now, most of the reports that are out there are focused on the diagnosis in children, but this can occur in adults. There was a recent paper that was published in a cohort of primarily adult patients with idiopathic polyarteritis nodosa that were screened for adenosine deaminase 2 mutations. And 4 of 118 of those patients were found to have biallelic mutations that were pathogenic. So about 3% of that population. And 2 of those actually were diagnosed with vasculitis in adulthood. And so the purpose of this paper is just to raise awareness that we do need to recognize this disease in adults. And so I'm going to describe 3 cases that have been published previously. All these cases did have ADA2 gene sequencing done. And 2 of the cases we had ADA2 levels. In case 1, we checked the enzymatic activity, and in case 2, the ADA2 levels. And these were compared to data 2 patients, carriers, and healthy controls. In case 2, we were not able to actually get peripheral ADA2 levels. But the fact that his brother was diagnosed with it and had the same genetic mutations helped to make that diagnosis. So the first case is a 19-year-old female who is presenting with a longstanding history of idiopathic polyarteritis nodosa and basically coming in to establish care. So her history dates back to childhood at the age of 6 when she developed these recurrent fevers, lower extremity pain, and eventually she started getting these headaches that on physical exam, there was nodularity of the temporal artery. So this led to a temporal artery biopsy, which ended up showing vasculitis of the temporal artery. And I'll show you those here in a second. She also had imaging of the mesenteric tract and found to have microaneurysms in the mesenteric arteries and the renal arteries. And she developed recurrent strokes as a child. She was initially treated with cyclophosphamide and glucocorticoids. Eventually, the cyclophosphamide was transitioned to mycophenolate. Now, she had to be changed from the mycophenolate because she was getting persistent neurologic symptoms. And so she was actually changed to infliximab and methotrexate. And since she's been on the infliximab, she has not had any recurrence of her symptoms for a number of years. So based on her suggestive history, she was tested for data 2, including the she was found to have 2 genetic mutations in ADA2. And she had strongly reduced ADA2 enzymatic activity. And so the pictures here that I'm showing are of the temporal artery. C is actually a normal temporal artery, and A and B are her biopsy. And so what you see is that there's a hypertrophy of the medial and intimal layer of the temporal artery and this intense inflammatory infiltrate. And in B, you can see evidence of fibrinoid necrosis. So case 2 is a 40-year-old gentleman who, again, is presenting with this longstanding history of idiopathic polyarteritis nodosa, and he's presenting to the hospital with large volume hematemesis. He has a history of cirrhosis, and so this hematemesis is coming from esophageal varices. But he has a very interesting history. He has a history of childhood polyarthritis, also an unexplained vision loss as a child, these recurrent oral and genital ulcers. At the age of 20, he started to develop recurrent ischemic strokes. And he also developed a rash with a biopsy that showed a medium vessel vasculitic rash consistent at the time of polyarteritis nodosa. And then he has cirrhosis, as I mentioned. On labs, he has fairly profound lymphopenia and hypogammaglobulinemia. And so based on his suggestive history, he was tested and he was found to have heterozygous mutations for ADA2. And he was subsequently started on etanercept. Now, he was actually, to this point, he was on a low dose of prednisone of 7 milligrams daily. And every time he would try to taper that prednisone, he'd get this rash that recurred. And so with etanercept, he was actually able to taper almost completely off the prednisone. But unfortunately, he did die of complications related to his end-stage liver disease. And so I've shown some of the autopsy findings here. A through C are actually of an infarction in the basal ganglia, and there's a cavitary lesion here. Now, what's interesting here is he actually did not have significant findings on a recent brain MRI. So this suggests that these are very small vessels that are being affected. Um, and then slides D through F are of the liver. And so what you see in D and E are this nodular regenerative hyperplasia pattern. And then in F, this is a trichrome Mason stain showing evidence of fibrosis. Now, case 3 is actually case 2's brother. It's a 43-year-old gentleman who presented after his brother was diagnosed. And he also had some interesting things in his history. So again, he had polyarthritis starting at the age 5. He has a history of stage 4 Hodgkin's lymphoma, which started at age 8. At age 24, he developed a left-sided numbness and bilateral sensorineural hearing loss. And then at age 29, he developed pulmonary hypertension and congestive heart failure, which at the time was thought related to the medications used to treat the Hodgkin's lymphoma. But there's quite a bit of time that elapsed between the two events. So he was also found to have the same genetic mutations as his brother, and we were able to test the ADA2 levels, and it was similar to other patients with DATA2. So he was treated with adalimumab, and he did not have any progression of his neurologic symptoms, and he had improvement in joint pains as well. And he's been doing well on that for a number of years. So these cases just emphasize the importance that we need to recognize the DATA2 phenotype in adults, because some of them will have had symptoms that started in childhood, and there are some that actually start with symptoms in adulthood as well, generally early adulthood. If we don't recognize these early, it's possible that these could result in morbidity and mortality, such as in case 2. And we do have an effective treatment, that being TNF inhibitors. And TNF inhibitors are not a medication we typically reach for at the start for idiopathic PAN. So that's why it's important to recognize this phenotype. These cases also highlight what previously was, is the first manifestation or the first description of involvement of the temporal artery, which is in case 1. It also highlights the liver pathology that can be seen in DATA2. And also in case 3, it highlights the concurrence of DATA2 with lymphoproliferative diseases, which others have recognized as well. Thank you.